Yes. His wife, unfortunately, doesn't travel much. We don't get to see it much. Yes. He's big on Twitter.
Oh, is he?
With most of his commentary about the world.
Oh, really? Oh, I didn't follow.
He's very funny.
Oh, is he? No, I didn't
Yeah.
see that.
Yeah, no, I didn't either. And one day when I kind of started to trust this.
Okay, that was pretty good.
I let him.
Yeah. Normal. Really?
And then he's got all this stuff around COVID and. Then he just goes after them. But in a funny way. And then they all go after him. For some filter. Yeah, hesitant.
Right.
All right, good morning, everybody. We'll get started for those on Zoom as well. So it's a great privilege and honor to introduce Dr. Eric Isselbacher, coming from across town. He went to Harvard for both undergraduate and medical school, and then went to residency and cardiology fellowship at MGH and has been there on faculty ever since. In 1996, he co-founded IRAD, which is the International Registry for Acute Aortic Dissection. And really, that has been the foundation from which much of our understanding of aortic dissection has evolved over the last couple of decades. In 1999, he co-founded and co-directed the Thoracic Aortic Center at MGH, and has authored over 150 research manuscripts and 50 book chapters focused on aortic disease and vascular disease. He's also the founder and director of the MGH Healthcare Transformation Lab, which is focusing on improvement in the experience and value of healthcare through an innovative collaboration. So most pertinent to his presentation today, Dr. Isselbacher is an internationally recognized expert in aortic disease. He's really a true leader in the field. I'll say what's most prominent, for me and others is making the cardiologist such an important role in the management of aortic disease, something that has traditionally been more of a surgical specialty, really showing how important our role can be in the management of these patients. He was the chair of the writing committee of the 2022 ACC AHA guideline for the diagnosis and management of aortic disease. And as you'll see today, it's really a comprehensive, really a wonderful guideline that gives you some great guidance on how to manage these patients, but also some flexibility where there's equipoise remaining with the rapidly evolving data. So I'll just say from a personal note, I don't know Dr. Isselbacher overly well, but we've met a few times over the years. And when I first came on faculty here, I was always a little intimidated when a patient would say they had their second opinion across town with Dr. Isselbacher. But I always look forward to it. It was always one I welcomed because I enjoyed reading his notes, always learned something, as we all will today. So thanks so much for coming, Dr. Isselbacher.
Well, thanks, Brett, for that kind introduction. And it's always a pleasure to come across town. And this is really the nicest venue I've been to yet. So I really, I'm glad to be here. So today, I'm going to try to walk you through a little bit about how these 2022 guidelines impact clinical practice. Let's see. I've got no relationships to disclose. So as Brett mentioned, these guidelines came out a year and a half ago. This effort was led by both the AHA and ACC, but just to drive home the point, these were really collaborative guidelines, and These were developed in collaboration with and endorsed by some key organizations, including the AATS, STS, and SVS. So the aortic surgeons were very much involved with these and endorsed the recommendations. And they were also endorsed by the Society for Vascular Medicine. So these are really guidelines that we all can and should try to follow collectively. These are comprehensive, and there are 270 recommendations. Obviously, we can't go through them one by one. So what I want to do is highlight 5 topics that I think are relevant for the cardiologist managing this disease. We won't get into more of the detailed surgical aspects of it, but as a clinical cardiologist encountering patients with aortic disease in the inpatient or outpatient setting, I think these are 5 things to kind of update your clinical approach. So the things we're going to talk about are the definition of dilation and aneurysm of the aortic root and ascending aorta, the part that we deal with most often. Some diagnostic imaging considerations, both as the clinician, but also as the person interpreting the diagnostic studies. Current medical management. Importantly, the updated thresholds for surgical repair of the aortic root and ascending aorta, and the importance of multidisciplinary aortic teams. Given the limited time, we're not going to talk about the descending or thoraco-abdominal aorta, certainly not going to talk about the abdominal aorta. We're not going to talk about my favorite topic, which is aortic dissection, but instead focus on the more general cardiology aspects of this. So one thing I want to do just to start, we're all comfortable distinguishing the abdominal aorta from the thoracic aorta. These conditions don't necessarily track together. They have some different risk factors. So we've gotten used to distinguishing these. But people still tend to lump the thoracic aorta together, and we really shouldn't, because the ascending or proximal aorta and descending aorta really behave differently. If you look at it, patients who have descending aortic aneurysms, these typically occur at advanced ages in patients with risk factors like hypertension, atherosclerosis, and smoking. On the other hand, the proximal aortic disease occurs at much younger ages. These tend to be sporadic in many cases, but we also see them in connective tissue disorders like Marfan syndrome. We see them in patients with bicuspid valve, and we see them run in families. And so because of that, we encounter these in a very different population than diseases of the descending aorta. As cardiologists, we mostly deal with the proximal aorta. And so the parts of the guidelines we're going to talk about today will be specifically focused on the proximal aorta, not the distal aorta. If we think about the prevalence of thoracic aortic aneurysms, we actually don't know the prevalence. And why is that? Because there's been no agreed upon definition of dilation or aneurysm of the aortic root or ascending aorta. Why is that? You might say, look, I've read the Society of Vascular Surgery's guidelines, and they offer a standard definition of an aneurysm, and that's 1.5 times the expected normal diameter of a blood vessel. But if we apply that to the proximal aorta, if you have a 40-year-old man with Marfan syndrome, the expected normal aortic root diameter would be 3.5 centimeters. So the aorta wouldn't be considered an aneurysm until it's 5.25 centimeters, but this patient should be in the OR by 5 centimeters. So we'd be saying patient merits surgery before it's even called an aneurysm, which makes no sense. If you look historically, research studies have used a variety of cut points anywhere from 4.5 to 5.5 centimeters. And you can imagine if you use all these different cut points, you're going to get dramatically different prevalences in different reports. And it becomes very difficult to compare studies, to compare populations, et cetera. So although this seems like a basic point, we figured that from a diagnostic and research perspective, we really needed to at least set some basic parameters. So how do we go about defining what's dilated and what's an aneurysm? Well, we looked at a number of historical studies, and a few of the most important ones I'm going to share with you. This is from Tyrone David and his group in Toronto, following 200 patients with bicuspid valve who underwent AVR, but not a concomitant aortic repair. And they followed them over 10 to 15 years. And what they found, as you can see here, those who had a diameter of more than 4.5 centimeters of the ascending aorta had a significantly increased risk of future complications. And you can even see that for those who had diameters of 4 centimeters, their risk increased over the years as well. But 4.5 certainly seemed like a number where things clearly were at increased risk. Then John Eleftheriades, one of the leaders in aortic disease, and his group at Yale looked to define the distribution of aortic diameters within the general population using the MESA database. They had over 6,800 patients without overt cardiovascular disease, of which more than 3,500 had MRIs of the thoracic aorta, and they looked at the diameters from those MRIs, and you can see this nice normal distribution here. But if you then zoom in on the right-hand side of the distribution, what you find is that about 2.6% have diameters 4 to 4.4 centimeters. That's 2 standard deviations above the mean. So these seem like outliers. And then when you get to 4.5 centimeters or greater, you're 3 centimeters above, 3 standard deviations above the mean, and only 0.2% of the population. So it seems reasonable to consider 4 an outlier and 4.5 clearly in the pathologic range. Then this group went on and they compared the risk of aortic dissection at various diameters. And what they did is they took this distribution and applied it to the distribution of aortic diameters in the International Registry of Aortic Dissection, which Brett had mentioned. And what they found was that relative to the normal ascending aortic diameter of 3.4 centimeters or less, those who had a diameter of 4 to 4.4 centimeters, it conferred an 89-fold increase in the risk of aortic dissection. And when you get to 4.5 centimeters or greater, it was a 6,000-fold increase in the risk of aortic dissection. So again, this kind of supports the idea that 4 centimeters is abnormal enough that you should pay attention. When you get to 4.5, it's worth really flagging these patients. So we recommended in the guidelines that 4 to 4.5 centimeters should be considered dilated, not an aneurysm. And when you use that A word, it alarms patients and it alarms primary care doctors. And so saying dilated, you're saying it's abnormal, but you're not saying it's all that bad. When you get to 4.5 centimeters, then you can use the A word and call it an aneurysm. Now, it goes without saying that this is for the average size patient, and we recognize that you wouldn't necessarily use these same cut points for a small woman or a very tall man, but for the average size patient, this is just a good general approach. I have to say, across town, the radiologists are constantly saying 3.8 centimeter ascending aortic aneurysm. That immediately sends a consult to me for a 3.8 centimeter aorta, and the word aneurysm makes the patient incredibly anxious, and we've got to get that word out of the report so that people don't worry about it so much. So speaking of imaging, this seems like a mundane topic, but it's actually not. About 10 years ago, 12 years ago, we got a group, an international group together in Chicago to try to define or agree upon how we measure the aorta and how we report the aorta, and we left the meeting unable to come to any consensus whatsoever. So we thought we would use this guideline to try to at least move in the direction of some uniformity and clarity. So the 2 major methods that are used to measure the aorta, of course, the proximal aorta, are echo and CT, as well as MRI, but mostly CT. So what are the issues there? For echo, as many of you know, the American Society of Echocardiography recommends using the leading edge to leading edge method. Now, anybody who is an engineer or appreciates physics would recognize that there's no anatomic or physiologic reason to do leading edge to leading edge. It's not clinically logical. The only reason it's there is because when echo was first introduced with M mode, it was basically the surface that reflects best, sending the signal back. So that was reasonable at the time, but we've moved on from there. We have 2D, we have 3D, but we're still wedded to this technique. Nevertheless, many labs have recognized the limits of the leading edge to leading edge method and measure from the inner edge to inner edge. So since the ASE wasn't willing to do it, we went ahead and said using the inner edge to inner edge method may be considered. So it wasn't too provocative for the ASE, but hopefully this is the first step to moving the community back to looking inner edge to inner edge on echocardiography. For CT and MRI, there's still a problem. Many radiology groups will measure the outer edge to the outer edge. At least this has anatomic logic to it. But others will measure the inner edge to the inner edge. Physiologically, the inner edge makes more sense. And after all, why are you giving a contrast load to do a CTA if you're then going to ignore the interface of the blood in the aorta and measure the outer edge? You didn't have to use contrast for that. So what we said was when performing tomographic imaging of the root and ascending aorta, measure inner edge to inner edge, and certainly use ECG synchronized technique, cardiac gated imaging, so that you eliminate the motion artifact as much as possible. Certainly, if you've got aortic wall thickening or abnormalities, if you've got a patient with aortitis, you can measure the outer edge to the outer edge. You might want to report both. But generally speaking, for the proximal aorta, the inner edge to inner edge. What about the aortic root? Radiologists love to measure the aortic root this way, sinus to commissure. It looks very nice. It's very geometric. But is that really the thing that makes the most sense physiologically? Physiologically, it's really the greatest diameter that's going to determine the wall stress. And so many groups instead measure it sinus to sinus. So we felt that this was the logical way to measure it. And in fact, the differences can be significant. Look at this short axis TEE measured sinus to commissure. We get diameters in this range, and then you do it sinus to sinus, and you get diameters that are 4 to 5 millimeters larger. That has a big impact on your decision making. And also from one study to the next, you could report rapid growth when really it's just due to the way the aorta is being measured. So the guidelines say the aortic root should be measured from sinus to sinus. If it's asymmetric, report both the short and long axis views of the aortic root. Also, this is a good example of why the American Society of Echo's leading edge to leading edge doesn't work. How do you measure something that's horizontal like this? You don't have a leading edge or a leading edge. You've got to use inner edge to inner edge. So reaffirming the inner edge to inner edge approach. Now, sometimes you can get asymmetric aortic roots, in particular with patients with bicuspid valve disease. And you can even get asymmetric ascending aortas, in which case what we recommend is reporting the largest diameter and its perpendicular diameter so that a surgical decision-making can incorporate both diameters in ultimately deciding on what the aortic diameter is and how much it's grown. All right, so that's kind of the background from the diagnostic standpoint. In terms of managing our patients with dissection, we just want to remind you, of course, the natural history that all of you know, which is aneurysms grow over the patient's lifetime, and if that growth goes unchecked, bad things will happen. So our first job, clinically taking care of these patients, of course, is to try to manage them medically, to do our best to slow the rate of growth and ideally reduce aortic events. Beta blockers are familiar to all of you. It's amazing that this is now a 30-year-old paper from the New England Journal, which was the first paper clearly demonstrating the benefit of beta blockers in Marfan syndrome. No question, treatment group on the right fares better in terms of growth than those in the control group. And in terms of outcome, you can see that beta blockers improve survival free of death, dissection, heart failure, or aortic surgery. So beta blockers then became the mainstay of therapy for Marfan syndrome 30 years ago. In terms of the clinical trials of beta blockers and aneurysms of other etiologies, you're looking at all of the studies right here. There are none. So basically, we've extrapolated from that original trial in Marfan syndrome to say beta blockers should be the mainstay of therapy for all patients with thoracic aortic aneurysms, although the data doesn't necessarily support it, but we have no other good options, at least until recently. So are there other potential therapeutic strategies? Well, at least if we start with Marfan syndrome, I think many of you are aware of the work from Hal Dietz and his colleagues at Hopkins, who discovered that Marfan syndrome is associated, of course, with a deficiency of fibrillin 1, but that leads to decreased sequestration of TGF-beta, which leads to overactivity of TGF-beta, which in turn is associated with medial degeneration. So it seems to be a causal mechanism. Then they demonstrated that an anti-TGF-beta antibody could blunt the rate of aortic growth in mice, which is a great thing, except it's not a very convenient therapy. They also recognized that angiotensin II receptor blockers, such as losartan, happen to inhibit the activity of TGF-beta as well. So they decided to study the effect of losartan on aortic root growth in their mouse model of Marfan syndrome. And you can see here, this is the normal growth in the control mouse. Here's the rapid growth in the Marfan mouse. Treat the mouse with propranolol and growth is slowed. So that supports the idea that beta blockers are effective. Treat the Marfan mouse with losartan and growth is slowed even more. In fact, all the way back to control. There's no growth or no abnormal growth. Now you might say, well, maybe losartan's a better antihypertensive, and that's really what we're seeing as the difference between propranolol and losartan. But if you look histologically, here's the normal control mouse aortic wall. You can see the intact elastic fibers in the wall with smooth muscle cells between them. Here's the Marfan mouse. Those elastic fibers are all fragmented, and there's smooth muscle cell apoptosis. Here's the propranolol treated mouse. It looks a little bit better, but still distinctly abnormal. And then here's the losartan treated Marfan mouse. The wall looks the same as control. So this isn't just a blood pressure effect. There's clearly a metabolic effect on the wall of the aorta. So the architecture is far more normal. So,
in that study, the original study from Southeast, was that started though early on?
it was started early on. Right, it wasn't late treatment, absolutely. But it suggested it could at least stop the metabolic pathway that would be a longitudinal, but you're absolutely right. So it was very good news in the mouse model of Marfan syndrome. And so the goal was then to study it in the human model. And this was a huge problem. No patients wanted to enroll because everybody now wanted to be on losartan. And it took years to accomplish this. And so finally, a Children's Hospital led a pediatric heart network study. It took 21 centers to get just 600 subjects who agreed to be randomized. And they were randomized head-to-head atenolol versus losartan. And then they were followed for imaging over 3 years. So very much like with the mouse model, beta blocker versus ARB head-to-head trial. And what they found was no difference. So what was supposed to cure Marfan syndrome, the good news, it did as well as a beta blocker, but it certainly didn't do any better than a beta blocker. And so just a sobering reminder that you've got to do the trials in humans. And while all the patients rushed to losartan, in fact, it wasn't the miracle cure we hoped it was. Well, that study was only 3 years. Maybe you need more time. Here's a longer 9-year trial of losartan versus atenolol. And you can see no difference between the two, even after 9 years. Again, losartan seems to be as good, but not any better. So now at least we have an option. If a patient's got a heart rate of 55 or has asthma, we can use an ARB rather than a beta blocker. They're equal, so you could use either one. Is there a benefit to both of them? There's not a lot of data here, but it suggests that both agents are probably better than one agent alone. So that's a good combination if you've got extra blood pressure room for 2 agents. What other therapies might be potentially beneficial? Well, statin therapy, there's a reason to suspect this might be helpful. There's excessive MMP9 activity in the walls of ascending aortic aneurysms. And we know that statin therapy is associated with reduction in MMP9. So perhaps statin therapies could act via this mechanism to slow the growth of aneurysms. So this is a study from Cleveland Clinic. What they did is they took all the patients with bicuspid aortic stenosis coming into the operating room for AVR, and they looked at the size of the ascending aorta and those who had been on statins for any reason versus those who hadn't been on statins. And they looked to just see how they compared, and they found that the statin group had diameters that were about 3 millimeters smaller than those who hadn't been on statins. The group at Northwestern did a similar analysis of bicuspid valve patients coming into the OR, but rather than stratify by statin or no statin, they simply took this 4.5 centimeter threshold and looked at those with larger aortas, what we would call an aneurysm, and those with smaller aortas. And then they controlled for age, body surface area, gender, hypertension, the valve function, and what meds they may have been on preoperatively, including ACEs, ARBs, and beta blockers. And what they found was that those with the larger aortas had a 0.66 lower odds of having been on a statin preoperatively compared to those with small aortas. So basically the same association, again, in this population. And then two more studies. This was a propensity matched analysis from a group in Italy looking at aortic diameter by echo over 3 years based on whether patients, this was not randomized, whether they were or were not on statins for whatever reason, and those on statins had slower rates of aortic growth, and those on statins had lower event rates, dissection, death, or cardiac surgery over the following 3 years. So another interesting association. And then finally, I mentioned John Eleftheriades and his group at Yale. They have the largest database of aortic aneurysms in the country. And here you can see over a 10-year period, they followed this group. And this is simply survival free of death, dissection, rupture, or operative repair versus statin use. You'd assume that those on statins had atherosclerotic cardiovascular disease. So over 10 years, they might have higher rates of death due to MI and stroke. Yet the people on statins, as you can see in the dotted line, fared far better over 10 years than those who weren't on statins. So again, provocative association. Ideally, what we would need would be a randomized clinical trial. It's just never going to happen. It would be far too expensive and take far too long. So we're kind of left with this data. So promising association. I think if you've got any reason to use a statin, you certainly should. A good opportunity for shared decision-making with your patients. So what we formally put in the guidelines is that beta blockers and or ARBs should be the primary therapy. If you've got room for 2 agents, use both of these agents as your first 2. Target blood pressure should be less than 130. Ideally, particularly for younger patients, get it down to less than 120 if they tolerate it. And then if there's any evidence of atherosclerosis, you see some coronary calcium or aortic calcium on your CAT scan, certainly use a statin. But even if they don't have any atherosclerosis, you could still justify using a statin, again, I think with shared decision-making. All right, so we talked about the natural history. Our first effort is to slow the rate of growth, but we know that that only does so much. And if we want to prevent the dissection or rupture from occurring, what we need to do is offer our patients timely intervention. So in terms of the indications for intervention, size remains the primary driver of these decisions. But let's just jump into the most common group we see, which are the sporadic aortic root and ascending aortic aneurysms. Unchanged in the guidelines is if you have a symptomatic aneurysm, you go to the OR. That's pretty straightforward. We'd previously said rapid aortic growth is an indication for surgery. The old guidelines had said 0.5 centimeters per year was rapid growth, but it's much more common that the growth isn't that fast, but it's slower and steadier. So we now include 0.3 centimeters per year over 2 or more consecutive years. So that's what we'll see more commonly, and that is sending more patients to the OR. And I think we're also all familiar with the guidelines years ago mentioned that asymptomatic aneurysms 5.5 centimeters or larger, that's a class 1 indication. And this 5.5 centimeter number seems to come up all the time for aortic disease. And it just seemed to appear magically out of the blue, as if it was handed down on tablets. I'm at the BI, I can do this thing. But it came from another set of tablets. It came from that group at Yale. John Eleftheriades and his colleagues were behind this. Now, they have the largest cohort, but when they started 25 years ago or more than that, they had a smaller cohort, only 230 patients back when they published this really key article. And what they did is they looked at the percentage point increase in the probability of complications of aortic aneurysms based on aneurysm size. And what you can see obviously here is it's this huge inflection point at 5.75 centimeters. Now, their logic was you don't want to wait till that happens because that's when everything goes wrong. So operate before that, operate at 5.5 centimeters. And that's where the 5.5 centimeter number comes from. And that was then codified. It was codified in our 2010 ACCHA guidelines, and then in the 2013 STS guidelines, and then in the 2014 European guidelines. Everybody agreed now 5.5 centimeters is the magic number. Well, that seemed good, and we all patted ourselves on the back for identifying the appropriate surgical threshold. If you take a look at the patients in IRAD, and you look at the diameters of their aortas when they actually dissected, you see this fairly normal distribution. And then if you look at our 5.5 centimeter threshold here, it's actually quite high up in this distribution because the mean diameter at dissection was only 5.3 centimeters. In fact, if we look at these, 59% of patients had dissections occur at diameters below our recommended surgical threshold. So if Brett saw all these patients in the clinic last week, he would have said to 59% of them, you don't need surgery, and yet they were going to go on to aortic dissection. So this was very disheartening, and it made us rethink, should we be operating at lower thresholds in some of these people, and how do we go about it, looking at that? Well, the Yale group then went back in the modern series, which was now up to 780 patients with unoperated ascending aortic aneurysms. And this is what they found. There was still that hinge point at 5.75 centimeters, but they found this earlier hinge point at just 5.25 centimeters. So that may be where the bad things actually start happening. So the logic there would be operate before you get to 5.25, which would be say 5, operate at 5 centimeters. So that's all well and good, but we have to remember that operations on a patient carry a risk. So we've got to make sure that if we're going to advocate for operating earlier to prevent bad things from happening, that we don't cause them at the same time. So we need to look at the risk of ascending aortic repair in the population. So this is a really important study from Chad Hughes and his colleagues. They looked at more than 13,000 elective aortic root or ascending aortic repairs performed over a 4-year period at 741 North American hospitals. And you can see here that the odds ratio for mortality drops significantly with annual case volume. And by the time you get up to 30 to 40 cases per year, your mortality drops about 3-fold. So those small hospitals have a significantly higher event rate than larger hospitals operating on aortic disease. These findings were proven again in this study here. If you look at red, which is the actual mortality, you can see a significant decrease in mortality as you get from the lower case volumes to the higher case volumes, getting down to a mortality of about 2%. So this is just hospital case volume. If you actually then take high volume hospitals with an expert aortic surgeon, you can see here the mortality gets to be down to about 1%, which is significantly lower than 3 to 5% in small volume hospitals. So how do we incorporate this? Well, let's take a look. What's the risk of an aortic event occurring? This is data from MGH, looking at the probability of dissection or rupture versus the ascending aortic diameter over the next 5 years. So taking this, if we say there's a 3% surgical risk in a low volume hospital, we can then justify operating at 5.5 centimeters, exactly what the guidelines have said all these years. But if that patient can be operated by an expert surgeon in a high volume center, we can lower the surgical mortality to 1%. Now we can justify operating at the 5 centimeter threshold rather than 5.5. But you've got to get that surgical mortality down if you're going to take that approach. So the key here is not just say to everybody operate at 5 centimeters, but say for selective centers with expert surgeons, you can consider operating at 5 centimeters. So how do we put that in the guidelines? Before we get there, the other thing we talked about, aside from just a high volume center, is a multidisciplinary team. That's what makes these expert surgeons have such low mortalities. So we defined a high volume center of at least 30 to 40 procedures per year. That's from that Chad Hughes paper. And then we defined a multidisciplinary aortic team as having cardiac surgical, vascular surgical, and endovascular specialists with extensive experience in managing complex aortic disease at a center with a high volume of aortic intervention. So it's the combination of the two. You have to have imaging specialists with expertise in all the relevant modalities. You've got to have anesthesiologists who are experts in acute aortic disease and CSF drainage. That really applies to the thoracoabdominal aortas. And an ICU experience in the management of acute aortic disease. We went on to say that we've lowered the size thresholds for many types of elective aneurysm repairs when the procedures are performed by expert surgeons in a multidisciplinary aortic team in light of the expected lower surgical risk. So again, saying it's really only in this setting that we can lower the threshold. And we also went on to say for patients who are asymptomatic, who've got extensive aortic disease, or who may benefit from complex open and endovascular repairs, or who have multiple comorbidities, for whom intervention is considered, referral to a high volume center with experienced surgeons and a multidisciplinary aortic team is reasonable to optimize the outcomes. Now, this isn't entirely new. In the valve guidelines, they emphasized the expert valve centers, particularly for mitral valve disease and mitral valve repairs. And this is that same kind of thing, saying that our thresholds and recommendations should not be the same in all clinical settings. So getting back to the sporadic aortic root or ascending aortic aneurysms, we talked about asymptomatic aneurysms should be operated on at 5.5 centimeters as a class 1 indication, but the new recommendation is that for asymptomatic patients, if the operation is performed by experienced surgeons in a multidisciplinary aortic team, it's reasonable to operate, class 2A, reasonable to operate at 5 centimeters or greater. So what about patient size and how does that factor into all of this? Well, I'm here with my two co-chairs from the guidelines, and you can see I'm considered pretty average in America. Jim here is taller than I am. Does the guideline apply to him? Ronnie is significantly shorter than I am. So what we recommend using is the aortic cross-sectional area to height index. We calculate that by the ratio of the maximal cross-sectional root or ascending aortic diameter area, in centimeters squared, divided by the patient's height in meters, with a threshold of 10 for that ratio. Where does that come from? This comes from two really important papers out of Cleveland Clinic. This first one is taking a look at patients with tricuspid aortic valves and associated aneurysms. Here for the aortic root, what you see in purple are patients who had a ratio of 10 or greater and were managed medically. They had poor outcomes. Those with ratios of 10 or greater who were managed surgically did far better, and in fact did as well as the patients with smaller aortas. But you can see in the top two, those who had ratios of less than 10, no difference between surgical and medical therapy. If you look at the ascending aorta, you see the same relationship here. Those with ratios of 10 or greater managed medically did poorly, managed surgically did far better. Less dramatic than the root example, but applies to both. They then went and looked at the same kind of relationship in patients with bicuspid aortic valves and aneurysms, and they found the same thing. If you've got a ratio of 10 or greater of the aortic root, you do poorly without surgery. Surgery brings you back to the natural history of those with small aneurysms. And the same thing again for the ascending aorta. So all of this supports this threshold of 10 centimeters squared per meter. So in the guidelines, we make that a class 2A recommendation. Patients who have a cross-sectional area at a height ratio of 10 or greater surgery is reasonable. But again, this was a study from Cleveland Clinic. So good outcomes at Cleveland Clinic aren't necessarily generalizable to any aortic surgical program. So we say when performed by experienced surgeons in a multidisciplinary aortic team. There are two other ways you can index. These are both from the group at Yale, aortic size index, which is normalizing by body surface area, or aortic height index, normalizing by patient height. We include these as 2B simply because the data isn't as robust as the data that Cleveland Clinic published for the ratio. So we kind of favor the ratio, but people can consider using any of these ways to index to the patient size. Now, we mentioned bicuspid valve. In the guidelines in 2010, we'd actually said bicuspid valve patients should be operated on lower surgical thresholds than sporadic aneurysms. because we thought it was more like a congenital disease and therefore more like Marfan syndrome, and people were having events at young ages, so it seemed logical to extrapolate. But actually, data suggested that patients with bicuspid valve disease were dissecting at actually larger diameters, a centimeter larger than tricuspid valve patients, which kind of threw a monkey wrench in the whole thing. So we subsequently corrected that in 2016 to say they should be treated like tricuspid valve patients. They're not at greater risk. So generally speaking, for patients with bicuspid valve disease, the standard is 5.5 centimeters if they have no high-risk features. If they do have high-risk features, which are shown below, then the class 2 indication 2A to operate at 5 centimeters. And even with no high-risk features, you can consider operating at that 5 centimeter threshold, provided it's done in experienced hands. What about Marfan syndrome? We do know that Marfan syndrome is more aggressive than sporadic or bicuspid valve disease. So for Marfan patients with no high-risk features, the threshold is lower. It's 5 centimeters for all comers. But if you've got features of increased risk, such as a family history of aortic dissection, rapid aortic growth, in Marfan syndrome, it's just 0.3 centimeters in 1 year is enough to be rapid growth. Diffuse aortic involvement, normally it's confined to the aortic root, but if it really involves the aortic root and ascending aorta, that would be a high-risk feature. And then marked vertebral arterial tortuosity. Any of these things should lead you to surgery at 4.5 centimeters. Now, in terms of genetic testing and screening of family members who are affected with thoracic aortic disease, there are 6 guideline recommendations, and rather than go through it this way, the easier way to approach it is with this algorithm, which is actually pretty simple. If you have features of a connective tissue disorder and an aneurysm, you should get genetic testing. If you have a known family history of aortic disease, or you've also got intracranial or peripheral aneurysms, then you clearly have what's likely to be an aortopathy, and you should get genetic testing. And if you've got aortic disease at a young age, this one is a little harder to argue, but we say go ahead and get genetic testing. But clearly people who are older, who have sporadic aneurysms, there isn't a primary role for genetic testing. That doesn't mean the family won't be affected. It just means it's less likely to yield a known genetic mutation. So here, what we do is we start with imaging the at-risk family members, first-degree relatives, all get screened. If none of them has an abnormal aorta, we're done. If someone else does, now we're talking about a familial aneurysm, and then we move over to genetic testing. So this is the way to approach screening the family and testing. And the ACC has a nice little tool online for cardiologists to use to kind of work through that. But I want to kind of wrap up the discussion of thresholds with the patients who have familial aneurysms that aren't syndromic. They don't have Marfan syndrome, and they don't have a known genetic cause for their aneurysm. So this previously was called familial thoracic aortic aneurysm. Now it's called non-syndromic heritable thoracic aortic disease and no identified genetic cause. So whichever one you call it, basically, these people do seem to be at high risk. When it runs in families, we see dissections at smaller sizes and younger ages. So we treat it very much like Marfan syndrome. So if you have no high-risk features of adverse events, just like Marfan, we operate at 5 centimeters. And if you have high-risk features, then you can operate earlier, just as with Marfan syndrome. So high-risk features are family history of a dissection at a small size or at a young age. We also include sudden death, unexplained sudden death at a young age, because often when they say, oh, my father died of a heart attack at age 45, and all you know is that he clutched his chest on the couch and fell over, well, that could have been an aortic dissection, not a heart attack. So unexplained sudden death at a young age also, and then rapid growth we've already talked about. This is one of the reasons to screen the family. You've got someone with a 5.2 centimeter aorta, and you're kind of in equipoise about whether to do something, and you screen his family and you find out that his sister has an aneurysm. Now it's familial. Now it's no longer a class 2 indication. It's a class 1 indication to go ahead and operate. Just to wrap up, what are our recommendations about physical activity and quality of life? For patients with significant aortic disease, we want to educate them about avoiding intense isometric exercises, burst exertion, and collision sports. For people who've undergone surgery, we recommend cardiac rehab, and you might wonder why on earth are we making this a recommendation? Isn't that obvious? It's because insurance companies don't pay for it or haven't paid for it. If you replace your aortic valve when you replace your aorta, they'll pay for it. If you do a single vessel bypass, they'll do it. But if you just replace, even if you do a valve sparing root repair, ascending aortic and hemiarch repair, they don't care. They're not going to pay for it. So this was a way to codify that so that they would have to pay for it. Are they paying for it? They're still trying not to, but we ask the patients to like highlight the guidelines and submit it because it's difficult to get them to pay for this. And then finally, 2A recommendations in patients with aortic disease whose blood pressure is adequately controlled. It's reasonable to encourage basically moderate aerobic exercise because it's good for their cardiovascular health, and there is evidence that it seems to improve the prognosis of aortic disease. And then finally, the importance of shared decision-making. We like to emphasize this in certain clinical settings when determining the appropriate threshold for intervention. 5.5 is a hard threshold, but beyond that, there are really 2A and 2B recommendations. And so there's an opportunity there to discuss with the patient what his or her preferences are. Deciding on the type of surgical repair, how extensive it should be. For the descending and thoraco-abdominal aorta, it would be surgical versus endovascular approaches. Medical management and surveillance, in particular, talking about things like statin therapy and what tools we'll use for surveillance. And then finally, and certainly most importantly, in pregnancy, ideally pre-pregnancy, to talk about the issues related to the risk of pregnancy, and certainly for women who are pregnant, considering the mode of delivery and things of that sort. So the take-home points are that we should use dilation for aortic diameters 4 to 4.4 centimeters, aneurysm when it's greater than or equal to 4.5, measure inner edge to inner edge and sinus to sinus. It's kind of an uphill battle. Screen first-degree relatives of patients with root and ascending aortic aneurysms, regardless of the etiology. Optimal medical therapy is beta blockers and ARBs as first-line plus minus statins. We've introduced the concept of the multidisciplinary aortic team, and with that, we've been able to lower the size thresholds for many types of aneurysms, provided that they're operated on in multidisciplinary aortic teams. And then for patients with complex thoracic aortic disease, they're best cared for in a multidisciplinary aortic team, and promote the use of shared decision-making when considering the surgical thresholds. So I always like to end with this slide, because this is the largest aortic aneurysm I've ever seen, 11 centimeters. And there's nothing like an 11-centimeter aneurysm to tell you that your time is up. So thanks very much for your attention.
Any questions for Dr. Schmuck? Sorry.
I have a question about the listeners who do specific, sorry, TGF-beta inhibitors. Anybody looked at this?
Not that I'm aware of. I don't know whether they're a little gun shy after what's happened with the losartan. Hal Dietz and his colleagues, I mean, candidly in this room, consider this a success. I mean, it's good, but it's not the success we were looking for. So I think we do need to try to find other pathways or other agents that might be more effective, but clearly getting from the mouse to the human is going to remain the biggest challenge. Yeah, that's a good point.
You say is one time enough, you treat them every 5 years, especially if their aneurysm showed up when they were 5 and their children.
So very important point. One thing this is not in the guidelines, but I avoid doing is I avoid screening them when they're children, when they're less than 18. Because unlike Marfan syndrome, if you have a bicuspid valve or if you have a sporadic aneurysm, nothing happens when people are kids in terms of the aorta. So I don't think there's any reason you need to go looking. The reason not to look is because the aortic diameter is often overcalled. Because it's hard to know how big the aorta should be relative to the size of the child. And I can't tell you how many times they're called dilated when they're 10, 15 years old, then they're 18 and suddenly they say it's normal now. Well, it didn't get normal. It was just overcalled. What's the downside of overcalling it? Because then some pediatrician or pediatric cardiologist says, don't play soccer, don't do anything, sit on the bench. There's no evidence for that recommendation either, but they say that. And then the kid suddenly becomes a sick kid for no good reason. So I encourage people, don't screen when they're kids. After 18 though, you're right, an 18-year-old may not have clear evidence of enlargement that might occur later. So I do say screen after they're adults. And then if they're completely normal, screen again in 10 years. And if there's no change, you're probably done. If they're upper limits of normal, then I would continue 10 years thereafter. But no one really knows because we don't really have enough longitudinal data to say when did the 65-year-old aorta first get to the point that it would have been detected. But I think once you're 30 years old, if your aorta is completely normal, then you probably do not have anything that would ultimately lead to an aortic aneurysm.
All right, Louise, so two questions, if that's okay. First question is, for non-syndromic thoracic aortic disease, is there a couple of kind of genome-wide association studies that have been published in this? Has anyone kind of looked at doing polygenic scores for that disease and seeing what it looks like?
Well, there are efforts to do that. It's just too far from clinical relevance at this point, because what we really got to do is to refine it so that we're screening a smaller population. So I think that's really the key, is getting it honed enough that we can justify screening a population based on that. And I think we've got a ways to go, but it's clearly moving in that direction. So I imagine that will ultimately be a useful clinical tool.
And the second question is for people, who are masters endurance athletes, see strong association with dilated aorta. How are you approaching that clinically when it comes to surgical thresholds and also advising about applying endurance?
Well, so I think that's really important, and it's not in the guidelines, and so I didn't include it in today's talk, but as you know, the cardiac performance program at Mass General did a study looking at senior endurance athletes and the size of their aortas versus controls, and they found that they're significantly larger. And it's basically that whole distribution is shifted to the right. So it doesn't look like it's necessarily pathology. It really looks like because of all of the other physiologic changes that are adaptive, the aorta enlarges as well. So whenever I see an athlete, I basically break out that paper and see that they fall within the normal distribution, and then say, well, actually, that's normal for you. And therefore, I'm not going to consider you to have an aortopathy. You're actually normal for an athlete of your size. But I think that that's something that really needs to be focused on, because we see more and more of these people whose aortas are abnormal, but they're really expected for that population.
I guess I have some prognostic significance.
It isn't understood, but I can tell you that I have not seen any of those people clinically in however many, 30 years presenting. And nor have I seen them go on later in life to have large aneurysms. So the population I see in their 60s, 70s, 80s with aneurysms, none of them were runners or rowers when they were younger. So they seem to just plateau in that 4-something range, and they don't go on to become big aneurysms later in life. But clearly we need to have longitudinal data on that. And the one other thing is that I didn't mention, we talked about size, and I talk about the 4 and the 4.5, and that's all well and good. But when you're trying to decide what is normal, you can have a 3.9 centimeter that's perfectly normal. You can have a 4.1 that's normal for a really big person. There are some calculators to use. Yale actually has a calculator for the ascending aorta that will tell you, because based on their population, what's normal and not. Then incorporates age, gender, height, weight. And then the Marfan Society has a Z-score calculator for the root for adults. And so those are useful when you have someone who's really small or really tall and you want to try to figure out, do they have pathology or not? Because some of these athletes are just really tall to begin with. And aside from being an endurance athlete, it's the fact that the guy is 6'5" that makes his aorta normal. It's not even that he's an athlete. But if you just read the radiology report, it will say dilated ascending aorta. And you can also use your judgment. You look at that CAT scan and the aorta looks normal to you. You look at the echo, relative to all the other structures, the ascending aorta is normal. So it is helpful to use some clinical judgment in deciding on what is actually normal and what is pathologic. But it's hard. We don't have hard and fast rules. Rob?
That was fantastic. Reminds me of my summer of '86, and I spent a fellow with Al Deeks and attending with Victor McHughes at 5 years before he identified variants. So my question is a little bit like his, and that is, we were the only people, by the way, under 7 feet. So that includes the women who were a couple 6'10". Anyway, are there any variants that really get you nervous, or is it just family history? It seems like it's family. Are there any really pathological variants that would kind of change the way you think?
Well, I mean, it's really when you get into like Loeys Dietz that you start to get nervous. But in terms of, say, something like Marfan syndrome, the family history ends up really being the, and for the familial aortic disease as well, while we don't view it with the same kind of drama as Marfan syndrome, the fact is it can be very pathologic. And so I think digging into the family history is key. So I remember I saw a woman with a 4.3 centimeter aorta, screened her family. Her sister had a 4.5 centimeter aorta. Okay, so it's familial. Then her sister dropped dead of an aortic dissection. So now we operate on her at 4.3 centimeters because of her family history. And it's so important to know the size of the aorta when a family member has a dissection. And that information is so often missing from the medical record that we put in a recommendation saying the surgeon who operates on an aortic dissection, class 1 has to put the size of the aorta in the operative report so that family members can find it, because you need to know how big that aorta was when it dissected. Because if it dissected, you hear someone who dissected at 7 centimeters, you say, that's great, you're only 4.5. You hear someone dissected at 4.5, completely different story. The family really tells the story about risk. Yeah.
So get rid of apologists.
Now, with regard to the statin data, do these studies use either statins or those?
This was if you had a statin, if you were on a statin, and again, for any length of time, so it didn't have to be lifelong, statin for any reason rolling into the operating room, which is what was so remarkable about it, to see that kind of effect. So you have to think, if you were on long-term statin therapy with a dilated aorta, it probably would have had more of a difference. I'm very liberal with the use of it, but I think the 2B recommendation was the best we could do.
3 questions on Zoom.
Okay.
The first is from Warren Getting. One of the presentations that greatly clarified prevention focus on aortic growth conditions.
Okay. The Lawrence not New Hampshire was called and said they
Well,
don't
the reason
sign.
that we
That's
didn't
what
include more granular detail
our
about
relatives.
intervals is because it really depends on
So they're canceling
size of the
credit card.
aorta
I
and
had a
the
feeling with
patient.
that.
If you find a 4
I
centimeter.
mean, they asked what the
aorta
relationship is. I put other, I put
you're not going to be very
hospital
worried and
records.
have to do aggressive surveillance imaging. You find that same thing in a 25-year-old, that may be different. But generally speaking, as a default, we say 6 months after you find it, repeat the imaging. The reason for that is not that most sporadic or bicuspid or even familial aneurysms grow that fast. They don't. What you're really looking for is aortitis. Aortitis grows rapidly. And if you don't catch that early, you'll miss the fact that the underlying diagnosis is aortitis. And then you may be a year or two into it before you recognize that, and you've lost that opportunity to treat. So the 6th month is to catch rapid growth. If it's that rapid, then you worry about aortitis and have to look for it. After that, you demonstrate no significant growth at 6 months, then you can go annually. And if you have no significant growth and you're talking about something in the low 4s, you can then go to every other year. And similarly, when you're talking about older patients, you can extend that even to every 3 years. But it really has to be individualized based on the starting size and the age of the patient, but it's very reasonable to extend those intervals when you're far from a surgical threshold.
What level of size would rank surgical versus catheter therapy? What approach should be patient?
Well, so that's a tough one because ideally anybody with a large aneurysm and aortic valve disease would get surgery. But then when you're talking about someone who's 84 years old, what's likely to be the problem? The valve, and can they live the next 10 years with their 5.2 centimeter aorta? They can. So I think if someone's a great surgical candidate, you might think about surgery, but generally speaking, leave the aneurysm alone, fix the valve. So we typically, if we weren't going to fix the aorta on its own, and if someone, say, in his or her 80s, or who has comorbidities, we would just deal with the valve and leave the aorta the way we would have otherwise. And it's sometimes hard to stomach that, but that's the way we approach it. There just isn't enough data on that. So the answer is no. There are potential other markers to better risk stratify. There's interest in the length of the aorta, that is from the aortic annulus up to the innominate artery, and that as that gets longer, the aorta may be weaker and therefore at greater risk. So that's being examined. There's 4D MRI to look at wall stress in these aneurysms. The problem is we can do that really well, but there's no way to get event rates out of it. We'd have to do 4D MRIs on thousands of patients and follow them for a decade before we could ever see how that's associated with the risk. And you can't do it retrospectively. So while that's really enticing, I don't see how that's ever actually going to turn into something we can use clinically in the modern era. So lots of work still to be done to risk stratify patients.
Great. Well, we're at the hour. Thanks so much, Dr. Isselbacher.
Thank you.